Hello, everyone, and welcome to today's broadcast, Antimicrobial Stewardship, its role in managing antibiotic resistance, presented by Dr. Haley Appaneal, Research Health Scientist, Providence VA Medical Center. I am Xavier Gutierrez of LabRoots, and I will be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears on the screen. Our speaker will respond to your questions via email. If you have trouble seeing or hearing the presentation, please click on the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Dr. Appaneal. I will now turn the presentation over to her.
Thank you for that introduction. Today, again, I'm going to be talking about antibiotic stewardship, and this is a topic I am very passionate about, antibiotic stewardship and its role in managing antibiotic resistance. So this presentation is in my view and not the view of the VA as a whole, and I have no conflicts to disclose. Today, again, I'm going to talk about the importance of antibiotic stewardship, identify some antibiotic-resistant pathogens, the ones we are most concerned about at this time, describe some current and emerging antibiotic stewardship strategies to target antibiotic resistance, and then assess some of the evidence out there for antibiotic stewardship. So first, we're going to start out and talk about why antibiotic stewardship is so important and why we critically have a need for antibiotic stewardship. So antibiotic resistance is one of the world's most pressing problems at this time. Infections that were once easily treatable by antibiotics are now becoming increasingly difficult to cure. And anytime we turn on the news, we can see evidence of this. We hear stories about superbugs and nightmare bacteria. Those are our carbapenem-resistant Enterobacteriaceae, or CRE. We hear how this world is running out of antibiotics, how antibiotic resistance is costing us billions of dollars a year in excess healthcare costs. So antibiotic resistance really is a huge burden. So I wanted to start out and get you guys thinking at home and ask you a question. You can answer this yourself, but I wanted to get an idea of what you thought the problem with antibiotic resistance was. So how many people in the United States do you think develop an infection due to an antibiotic resistant bacteria every year? Is it 50,000, 100,000, 500,000, 1 million, or 2 million? So for those of you that said 2 million, you are correct. The CDC estimated that in 2013, there were at least 2 million illnesses and 23,000 deaths every year that occurred due to antibiotic-resistant bacteria. This is a minimum and was data done in 2013, so it is likely an underestimate as well. So any discussion on antibiotic stewardship must begin with acknowledging how powerful antibiotics are. Antibiotics really enabled modern medicine as we know it, and the development of antibiotics is argumentably the most important advance in modern medicine at this time. The ability to cure infections that were once untreatable happened when antibiotics were developed. They enabled critical care medicine, complex surgeries, organ transplantation, and cancer chemotherapy. And it is estimated that the deaths in the United States declined by 220 per 100,000 in the 15 years since the development of sulfonamides and penicillin, much more than any other medical technology we've had. So conservative estimates about the absolute reduction in death mediated by antibiotics is quite remarkable. Community-acquired pneumonia, the death rate decreased about 25% between the pre-antibiotic period and after antibiotics were available commercially. Hospital-acquired pneumonia decreased 30%. Heart valve infections and brain infections decreasing 75%. And 60% with a mortality rate. Skin infections now are very rarely associated with mortality, but before antibiotics, they had a death rate of about 10%. So an absolute reduction of about 10%. All right. So in 2014, Jim O'Neill, who is an economist, was commissioned by the British government to release this report, which estimated the current death toll of antibiotic resistance worldwide, and that was at 700,000. And also he estimated that if resistance were allowed to grow unchecked, if there were no successful efforts to curb antibiotic resistance or no new drugs developed, that the death toll would rise to 10 million by 2050, which is just 30 years from now. And that's more than currently die from cancer and diabetes put together. Additionally, he showed that the deaths attributable to antibiotic resistance would fall unevenly across the world. So Africa and Asia would suffer some of the greatest losses, with 4 million deaths in each of those countries at this time. By 2050. Also, it must be noted that our problem with resistance is not only exacerbated by overuse in humans, but also in U.S. livestock. So in animals in the United States consume more than twice as many medically important antibiotics as humans. So not only do we need to focus on efforts to improve our use in humans, but animals as well, even though that will not be the focus of this talk. So now that we talked about just why antibiotic stewardship is so important, we'll now move on to some of our biggest concerns with regards to antibiotic resistance. So in 2009, the Infectious Diseases Society of America released this publication, Bad Bugs, No Drugs, and this was really to call attention to the crisis of antibiotic resistance and call for the development of new antibiotics, especially for these 6 resistant organisms that were increasingly escaping the effects of antibiotics. So they became known as the escape pathogens. And they are gram-positives, Enterococcus faecium, Staphylococcus aureus, and then gram-negatives, Klebsiella pneumoniae, Acinetobacter, Pseudomonas, and Enterobacter species. And then in 2013, the CDC published this report called Antibiotic Resistant Threats in the United States. And this outlines the top 18 drug-resistant threats in the United States at this time. And these are threats because they are resistant to our first-line and our second-line antibiotic treatment options. And sometimes even there are no commercially available options to treat these infections. So healthcare providers are forced to use antibiotics that may be more toxic and more expensive and less effective than other agents. And even when there are treatment options available, data has shown that patients with resistant infections are much more likely to die, have higher morbidity and mortality, have longer healthcare stays in the hospital, and have delayed recuperation time. So it is critically important for the public health to implement strategies to improve the way we use antibiotics. In this report, the CDC categorized bacteria into 3 levels of threat. That was urgent, for example, our carbapenem-resistant Enterobacteriaceae, serious, multi-drug-resistant Pseudomonas aeruginosa, and extended spectrum beta-lactamase producing Enterobacteriaceae, for example. And then the lowest level was concerning. So C. diff is one of the urgent threats. C. diff causes life-threatening diarrhea. It can be so severe that it may lead to hospitalization and even death. And these infections are not really a problem with resistance like some of the other ones, but more antibiotic use just leads to C. diff. So C. diff infections are, the primary driver is antibiotic use and exposure to the healthcare system. C. diff causes about 500,000 infections every year and 29,000 deaths at least, and causes millions in excess healthcare costs each year. When the CDC report came out, the estimate was that it caused 250,000 infections, but a subsequent report, 2015, showed that the burden was actually much higher at about 500,000 cases of C. diff a year in the United States. So resistance, again, is particularly a problem with our gram-negatives, and a number of gram-negatives were given urgent and serious level threats in this CDC report. In particular, our ESPL-producing Enterobacteriaceae, our CREs, multi-drug-resistant Pseudomonas, and multi-drug-resistant Acinetobacter, all causing a number of infections and deaths in the United States. Similar to the CDC, the World Health Organization established priority levels for some of our most concerning bacteria. Like the CDC, they gave Acinetobacter baumannii, Pseudomonas, Enterobacteriaceae, our carbapenem-resistant, and our ESBL-resistant Enterobacteriaceae high levels of threat. They put all of these in the critical level, which was their highest level of threat. So antibiotic resistance is now an international agenda. In May 2017, the G20 nations met and put this antimicrobial resistance international agenda document together, and they called for 3 strategies to combat this crisis of antibiotic resistance. And that was promoting conservation of antimicrobials, optimizing use, and investing in technologies to bring new antibiotics and diagnostics to the market. So antibiotic use directly leads to antibiotic resistance. It's widely known that inappropriate use leads to antibiotic resistance, but appropriate use often is less often cited as a cause of antibiotic resistance. There was a survey that was done in 2002, and greater than 90% of respondents, these were medical residents, I believe, they cited inappropriate use as a cause of resistance, but they were much less likely to cite appropriate use as a cause of resistance. So even if all inappropriate use were eliminated, we would still have antibiotic-resistant infections occur, but they would occur at a much lower frequency. And the problem is that we drastically overuse our antibiotics in the United States and worldwide. It's estimated that over 260 million courses of antibiotics are prescribed every year in the United States, and that's 5 prescriptions written for every 6 people. And greater than 50% of patients who are hospitalized receive at least 1 dose of antibiotics. So now just another question to, again, get you thinking. What % of antibiotic use is inappropriate in the United States? Is it less than 10%, 25%, 50%, 75%, or 100%? So you just think about that. And for those of you that said between 50 and 75%, you are correct. It does vary based on the healthcare setting, but it's thought that at least 30% is inappropriate in outpatient settings, 50% in acute care settings, with even higher rates in certain areas such as the ICU. And in long-term care settings, at least 75% of antibiotic use is inappropriate. So now we talked about antibiotic stewardship and why it's important. We talked about some of the problems with resistance and some of our greatest concerns, we'll talk about now some strategies to improve antibiotic use. So in 2007, the Infectious Diseases Society of America released guidelines for antibiotic stewardship in hospitals. And antibiotic stewardship is really the most important strategy to improve our use of antibiotics. And again, 2007 guidelines were released for hospitals. And since that time, antibiotic stewardship has been recommended across all healthcare settings, including long-term care facilities and outpatient settings. In 2016, updated guidelines for stewardship were released. And in both of these guidelines, antibiotic stewardship is defined as coordinated interventions to improve and measure the appropriate use of antibiotics by promoting the selection of optimal drug regimen, dose, duration of therapy, and route of administration. So you can think of it as any strategy to improve the drug, the dose, the duration, even the diagnosis, making sure the patient actually has an indication for an antibiotic. And two main strategies that are used are restriction and prior authorization, which is a front-end approach where providers must get authorization to use a certain antibiotic. And then there's also prospective audit and feedback, which is a back-end program, which is more what our facility does. And we review all patients who are on antibiotics, and then we make recommendations every day to improve the drug, the dose, the duration. We do de-escalation to improve our antibiotic treatment in our facility. So there are a number of different tools that can be used to make sure that our patients are getting the most appropriate treatment. When they are first started on antibiotics, we can have pathways and order sets that can be followed in the emergency department to make sure the correct antibiotics are chosen, and also to make sure the patient actually has an indication for an antibiotic. So for example, a lot of work has gone into urinary tract infection treatment pathways to make sure the patient actually has urinary symptoms and has a true UTI before we treat them. To create treatment pathways, we need to use national guidelines, but also the local antibiogram. And an antibiogram is a profile of antimicrobial susceptibility tests to the pathogens that are most common in your institution and common antibacterial agents used to treat those pathogens. And this allows for optimal selection of antibiotic therapy within an institution. We also need to consider patient risk factors for multi-drug resistant organisms, take cultures, and then appropriately follow up on those cultures and de-escalate treatment or stop treatment once the patient has clinically improved. So antibiotic stewardship programs have been shown to improve patient outcomes by reducing unnecessary antibiotic prescriptions, and also they reduce the unintended consequences of antibiotics such as adverse drug events and toxicities, also decrease C. difficile infections, decrease antibiotic resistance, and also if you do all of those things, you will decrease costs within the institution as well. So now I'm going to talk about two strategies that are gaining more and more evidence to support their use, and that is limiting the duration of therapy to the shortest effective course, and then also I'll talk a little bit about rapid diagnostic testing. So the history behind antibiotic durations and using extended durations of antibiotics dates back to the 1940s. At this time, it was recommended to administer penicillin to patients with pneumonia until there was definite clinical improvement and temperature had remained below 100 Fahrenheit for 12 hours. And then at that point, continued to treat for another 2 to 3 days. And the reason was that they thought they could prevent relapses by doing this. And this was based on a few case series where the patients had short courses. They said they had relapses, but when they went back and looked, these were actually reinfections with different bacterial species. So it is unclear how this belief that antibiotic resistance could be prevented by continuing therapy beyond symptom resolution. So continuing the treatment for another 2 to 3 days beyond the patient had completely responded, how that would actually prevent resistance. Actually, the opposite is true. Extended durations do not prevent resistance at all. There's been no evidence antibiotic use beyond the point of symptom resolution reduces antibiotic resistance. Studies have shown that long courses of therapy result in greater emergence of antibiotic resistance. For example, there was a randomized controlled trial, and this compared 8 versus 15 days of therapy for 200 patients with ventilator-associated pneumonia. And they found between the two groups, there was no difference in recurrent infections. About 30% of patients had recurrent infections in both groups, both the short and long course treatment. But among those who developed recurrent infections, less multi-drug resistant pathogens were identified in those who received 8 days of therapy. And quite a bit less too, 42% in the group on the shorter course of therapy, and 62% in the group on the longer course of therapy. So shorter course therapy really is better. There was this article released in JAMA Internal Medicine, which reviewed a number of the antibiotic trials comparing shorter versus longer durations of therapy for a variety of acute bacterial infections in adults. And essentially what they showed was that all trials studying this have found that short course therapy is just as effective as long course therapy for a number of different infections, such as community-acquired pneumonia, hospital pneumonia, cellulitis, COPD, for example. Excuse me. There was also this meta-analysis in May of 2008, and it studied clinical trials comparing short versus long courses of therapy for hospital inpatients with pneumonia, complicated UTI, intra-abdominal infections, and nosocomial infections of unknown origin. And across 13 trials that included efficacy data in almost 3,000 patients, they found no difference in clinical cure, microbiological cure, mortality, or infection recurrence, comparing short versus long duration therapy. So the next thing we'll talk about for a strategy is rapid diagnostic testing. Rapid diagnostic testing and stewardship are linked. So effective antibiotic stewardship is closely linked with our ability to make correct diagnoses. However, antibiotics are rarely prescribed based on a definitive diagnosis. Most antibiotics are actually prescribed based on an empiric diagnosis where the provider will guess at whether the patient actually has an infection or not, and then what might be causing the infection. So they're guessing whether it's a bacteria versus a virus, for example, for a respiratory infection, and then they have to guess at what the most appropriate treatment is. So diagnostic tests can show whether or not an antibiotic may be actually needed and which one. However, using our traditional methods, these often take a number of days to get these results back. And so the patient has already been on treatment or maybe even completed their treatment by the time we get this information back. So using traditional approaches, it takes at least 24 hours to obtain growth from our clinical specimens, and then usually at least another 24 hours to isolate the pathogen. So typically it takes at least 48 hours for pathogen identification, and then another 48 to 72 hours for our antibiotic susceptibility test to come back. So as a consequence, therapeutic decisions are commonly made empirically, like I said before, and they're often started on very broad spectrum treatment until more clinical information becomes available. So with the emergence, increase of resistant organisms such as methicillin-resistant Staphylococcus aureus, our resistant gram-negatives such as ESBLs and carbapenemase, resistant Enterobacteriaceae, multi-drug resistant Pseudomonas. Patients are often empirically started on very broad treatment, for example, with vancomycin and piperacillin tazobactam, and continued on that treatment for usually at least 3 days until we have more information and the cultural the antibiotic susceptibility results are back and we can narrow the patient's treatment. So if we had more rapid testing, we could significantly reduce this time that patients are on these broad spectrum therapies and get our patients on more appropriate treatment quicker. Rapid diagnostic testing just in respiratory illnesses could decrease the number of unnecessary antibiotics prescribed annually. Just with respiratory infections, just 27 million prescriptions could be avoided just for that alone. So rapid diagnostic testing could have a huge impact in improving the way we use antimicrobials. So a number of different approaches are available for rapid diagnostic testing, and this is a growing field which is actively getting more and more technology daily. And so there are a number of approaches. Some of these are culture dependent and some are culture independent, and some can be used at the point of care, and they can be used in emergency departments, ICUs, outpatient settings. I'm not going to go into the specifics of each of these, but know there are a number of different technologies that are being developed, and we can more rapidly identify our pathogens and resistance genes and determinants. So the role of diagnostic testing in stewardship, it could help us to identify pathogens, to guide the selection of the antibiotic agents that we use, to guide de-escalation from broad spectrum to narrow spectrum treatment, and also help with discontinuation of antibiotics. It can help in identifying resistance genes or markers that may predict antibiotic treatment failure. Can help with determining virulence factors, identifying antibiotic susceptibility to help predict which antibiotics may be most effective to treat the infection, distinguishing between viral and bacterial causes of infection, and can be used, some of them at the point of care. So for rapid diagnostic testing, it actually is most effective if it's implemented with antibiotic stewardship. And if an antibiotic stewardship program is in place, this is helpful because you'll have somebody to follow up on the results of the rapid tests quickly. So an intervention from the stewardship team is crucial for providing interpretation of these rapid diagnostic tests and initiating action from providers on these tests efficiently. So here's just one study that is an example of the use of a rapid diagnostic test with antibiotic stewardship. This study looked at MALDI-TOF and stewardship intervention in patients with pneumonia or bacteremia due to Acinetobacter. And they compared 66 patients before the intervention to 53 patients after the intervention. And they found significantly reduced time to effective antimicrobial therapy by 41 days, increased clinical cure by 19%. They also decreased the length of stay by 2 whole days. And all of this, there was no increase in 14-day mortality. And then also they looked at costs, which didn't significantly decrease, but they did show a decrease in costs as well, just for the small number of patients they looked at. Excuse me. So now I'll move on to looking at the evidence we have for stewardship programs in preventing antibiotic resistance. So a number of studies have shown that there's a high correlation between resistance to antibiotics and their previous use. Antibiotic stewardship programs have consistently demonstrated to decrease antibiotic use. So it would make sense that since we're decreasing antibiotic use, we would also be able to decrease resistance or slow the emergence of resistance. However, the studies that have actually assessed the impact of stewardship programs on resistance have been quite limited So again, stewardship programs are broadly considered important strategies in mitigating the global problem of antibiotic resistance. We have good data to support the effect of stewardship interventions in reducing our antibiotic use and antibiotic costs, but we have only limited data to show the effect of interventions on reducing or at least slowing the emergence of antibiotic resistance. A recent review of 221 studies on antibiotic stewardship interventions, only 20 of those actually assess the impact of antibiotic stewardship programs on antibiotic resistance. There was a Cochrane review that looked to estimate the effectiveness and safety of interventions to improve antibiotic prescribing in hospital inpatients. This was done in 2017, and they looked at 20 interrupted time series studies, and they actually found that there was very low evidence for stewardship interventions on reducing resistant infections due to gram-negative bacteria and gram-positive bacteria, but they did show good evidence for stewardship in decreasing C. diff infections. Another review, this one is a systematic review that was published in 2018, looked to analyze the role of stewardship programs specifically in reducing bacteria resistance to antibiotics in the hospital setting. They included 26 studies from 2012 to 2017. And so the two most appropriate study designs for evaluating the impact of stewardship programs are randomized controlled trials and our quasi-experimental studies that are controlled. So we have a pre-period compared to a post-period after the stewardship intervention. Those are considered to be the best study designs. Only 8 studies then in their review actually had this quasi-experimental design, and there were no randomized controlled trials. The other problem with these studies is that the antibiotic stewardship program strategies that were implemented, so IV to PO conversions, de-escalations, those type of things, they all differed quite a bit throughout the studies. And then the different microorganism antibiotic pairs that were evaluated varied widely between the studies. Only MRSA appeared in the great proportion of the studies, and that appeared in 12 out of the 26 studies they reviewed. So again, they found great heterogeneity between the studies, and this limited their ability to make conclusions and to pool the results. But looking at the different studies, they were able to show that only 27% of those studies, so 7 studies, showed clearly positive results in decreasing antibiotic resistance. So they concluded that there was no solid evidence that stewardship programs have in reducing antibiotic resistance in hospital settings. So they really called for more studies to be conducted, more high quality studies to study this issue. Our stewardship program was actually one of the studies they looked at in that review, and we published this study in 2016 in PLOS One, looking at the impact of our stewardship program, which again is more a prospective audit and feedback program. And we looked at resistance in addition to a number of different patient outcomes. So our stewardship program at the Providence VA is a prospective audit and feedback program, meaning that we review all inpatient antibiotic use, both oral and intravenous, daily from Monday to Friday. Our ID pharmacy fellows, residents, and students review all patients who are on antibiotic therapy, and then we make recommendations to our ID physician. Together, we determine if we want to go forward and make those recommendations to the team. And then if we feel we want to make the recommendation, we'll communicate that to the primary team taking care of the patient via either a telephone call or a note in the chart. And then we'll follow up on those interventions to determine whether they were accepted or not. So the study that we did was we compared a pre-intervention period. The first year of our program was compared to the pre-intervention period, which was also a year long. And we looked at a number of different outcomes. In particular, we looked at resistance. And so for our findings, for our gram-positive organism antibiotic combinations, we found no significant changes. And for our gram-negatives, we found, again, no significant changes, except for Kleb pneumo, which there were some increases in resistance. So this may seem like some negative results, but our trends for our resistance and our gram-negatives have been increasing. So it was impressive that in just the first year of our program, we only saw increases in resistance in one organism that we looked at. So that brings us to the end. And just in summary, our bacteria are now resistant to multiple classes of antibiotics. We don't have many new antibiotics in drug development, so we really need to preserve the antibiotics that we have left and utilize antibiotic stewardship principles to improve the way we use antibiotics. And so now I would like to open it up if anybody has any questions.
Thank you, Dr. Appaneal, for that informative presentation. We will now start the Q&A portion of the webinar, and I will address some of the most commonly asked questions by our viewers. If you have any questions you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. Our speaker will follow up with your questions via email. All right, let's get started. Our first question is, what were some of the most common types of interventions made by your antibiotic stewardship program in the first year after implementation, and have these changed now that the program has been running over 5 years?
Great. Yeah, so our interventions have changed. In the beginning, we were making some of more of the low level, they call them the low-lying fruit interventions, making a lot of recommendations for IV to PO conversions, making recommendations for vancomycin dosing and dosing of other antimicrobials, getting levels for drugs, in particular trough levels for our vancomycin. So those type of low-level interventions. And those made up probably the majority of our interventions at that time. And since that time, we've looked at our interventions and trying to improve some of more of the higher level interventions and things that may be a little bit harder to get providers to accept, such as duration of therapy and getting them to get patients discontinued off their antibiotics in a more shorter amount of time. And we actually have been able to do that. We compared our interventions in 2014, which was one of the first years of our program, to a later year, 2016. And we found that in 2016, we were making quite a bit more interventions throughout the year. We're a smaller facility, so at that time we were making about like 600 interventions a year compared to around 400 in 2014. And we found the greatest increase in our interventions was actually in making recommendations for discontinuation and duration. So those made up about 16% of the interventions in 2014 and almost 30% in 2016. And we found that providers are more likely to just switch patients IV to PO. They've learned throughout our program, we do a lot of education to just kind of do some of those more lower level interventions automatically now, and we don't have to make interventions for that type of thing.
Okay, and our second question is, besides antibiotic resistance, what were the other outcomes assessed to measure the impact of your antibiotic stewardship program?
Great, yeah, so resistance was just one of the aspects we looked at. We did a 6-point evaluation, which was kind of unique to our study. A lot of studies have just focused on antibiotic use and see what the impact of their program is there. But we looked at antibiotic use. We looked at clinical outcomes such as mortality, resistance, antibiotic costs. And so antibiotic use was the primary outcome we looked at. And we found that broad spectrum antibiotic use decreased, our use of fluoroquinolones decreased, our anti-pseudomodal agent use also decreased. So since our antibiotic use decreased, it makes sense. Our antibiotic costs also decreased. They decreased about 14% from the pre to the post period. And this, again, is just antibiotic costs, so it doesn't take into account anything else like nurses' time hanging the antibiotics, pharmacy costs, making the antibiotics, that type of thing. We also looked at patient safety outcomes. So we looked at C. diff rates pre and post, and we have a very low level of C. diff because we have great infection control at the Providence VA as well. So we didn't make any significant changes there, but our rate did stay low. And we also looked at average drug events. Those did decrease from the pre to the post period. Like I said, we also looked at patient outcomes. So we looked at mortality, which didn't change between the two periods. And then we had a trend toward a decreased length of stay. And we looked at readmission rates as well, which didn't change between the two time periods.
All right, and we are going to ask one more question. What are some recommendations for facilities looking to start an antibiotic stewardship program?
So one of the most important things is to look at your own data, so antibiotic use and resistance data, to try to identify areas of need or problem areas within your institution, and then target those. That helps to give you a goal and things to look at when you're looking to measure the impact of your program. Can also look to see if what you look to improve is actually improving, or if you need to make tweaks to your program. Also, there are a lot of great resources out there for programs looking to start a new stewardship intervention. There's both of the IDSA guidelines, both in 2007 and 2016, which are helpful. Then the CDC also has their core elements documents, which are also very helpful. And they have specific documents that hospitals can use, outpatient facilities, long-term care facilities, for example, that can be used, and they can implement some of those core strategies that the CDC recommends.
All right, well, I would like to once again thank Dr. Appaneal for her presentation. I would also like to thank LabRIID for making today's educational webcast possible. Now, before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through December of 2018. You will receive an email from LabRIID letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's event. That's all for now. Thank you for joining us, and we hope to see you again soon. Goodbye.